Now, when we're talking about pharmacology, there's pharmacokinetics and pharmacodynamics. These are really the subdivisions of the field. Now, pharmacodynamics is the effect that a drug has on the body. It's the way a drug works, the mechanism of drug action. So it might act on a synapse, for example, to stimulate a receptor. And the other kind of half of the field really is the pharmacokinetics. Kinetics means to do with movement. So pharmacokinetics is the effect that the body has on drugs. For example, the way that the body will metabolize and break down drugs. And the first thing I want to think about in this area of pharmacokinetics is this idea of first pass metabolism. First pass metabolism. Now, to understand this, we need to go back a little bit and look a bit at the circulation of the blood. Because the first pass metabolism is the metabolism that occurs the first time blood passes through the liver. The first time blood passes through the liver. So what's happening? Well, as you know, there's a heart here. And from the left ventricle, the aorta pumps blood out into the systemic circulation. So this is the aorta pumping out blood. And as you know, branches from the aorta go off to all of the tissues of the body, supplying the systemic arterial circulation. But down here there's a branch off that we're interested in today. And this branch here, the mesenteric artery, is going to take blood to the gastrointestinal tract. So here we have the gastrointestinal tract, which is essentially one long tube. And blood is drained from the gastrointestinal tract. And when I'm talking about the gastrointestinal tract, I'm pretty well talking about all of it. The stomach, the lower third of the esophagus, not the top 2/3 of the esophagus, but the lower thirds of the esophagus. All of the small intestine, the duodenum, ileum, jejunum, and all of the large intestine actually drains blood into this vessel here. So this is the gastrointestinal tract, and it drains blood into this vessel. And this vessel doesn't go straight back into the systemic circulation as most vessels do, but it actually drains the blood directly into the liver, just here. So the blood is going into the liver. And it's only when the blood has been through the liver that it drains back into the inferior vena cava, into a systemic vein, which is going to take the blood back to the right atrium. So this is the aorta here. This is the gut. This is the vena cava. So we see that the blood is going from the aorta around the body, but then there's the arterial supply to the gastrointestinal tract, taking blood to all of the gastrointestinal tract, which we'll draw in green today, I think. So that's all the gut there. But once the blood has been through the wall of the gastrointestinal tract, it drains into this vessel here. It'll be partly deoxygenated at this stage. The blood then drains through the liver before finally being drained. I traditionally draw the deoxygenated blood in blue, I suppose. So that's partly deoxygenated blood going through the liver. Actually, I mean, the blood draining the gastrointestinal tract is not deoxygenated. It's only about 75% deoxygenated, so it still contains quite a lot of oxygen. Then that blood's going to drain back to the right side of the heart to be pumped to the lungs to be reoxygenated. Now, this vein here, joining the gut to the liver, starts in capillaries in the gut and ends in capillaries in the liver, in the sinusoids in the liver. And this vein here is called the hepatic portal vein. And there's only two veins actually in the body that start in capillaries and end in capillaries. The other one is in the connecting the hypothalamus to the anterior pituitary gland. So now we understand this, the nature of the circulation, we're in a position to start to understand what we mean by first pass metabolism. So I'll just draw a much simplified diagram, I think, to try and explain this. So here we have the gastrointestinal tract, which, as we've said, is essentially one long tube. That's the gastrointestinal tract. And then we have the liver just here. The liver. That's the liver. And we have numerous blood vessels draining the gastrointestinal tract. The capillaries will drain into small veins, into larger veins. And these will all collect together to form the hepatic portal vein, taking the blood directly to the liver, which then breaks up into, again, numerous smaller veins, which will take the blood into the liver sinusoids, the sinusoids in the liver, which are the liver capillaries. The sinusoids are the liver capillaries. And as we've said, this is representing the lower third of the esophagus and all of the rest of the gastrointestinal tract, draining blood directly into the liver. Now, why does this happen? Well, in the gastrointestinal tract, of course, there's huge numbers of bacteria. And there's a bacteria metabolized, there's bacterial toxins produced. Now, we don't want these bacterial toxins to go directly back into the systemic circulation, because they would circulate all around the body. Because it's the liver that breaks up toxins. The liver breaks down toxins. So bacterial toxins will go from the gut to the liver, into the liver sinusoids. In the liver sinusoids, they come into contact with the individual liver cells. The individual liver cells, which are the hepatocytes. The hepatocytes. And it's these that will break down the toxins. And actually, even sometimes bacteria can get through. Bacteria can get through sometimes from the gastrointestinal tract and drain in the venous drainage of the gastrointestinal tract. Now, of course, the last thing you want is bacteria getting into the systemic circulation, because that would go all around the body and cause bacteremia and potential sepsis. So they go into the liver. In the liver sinusoids, there's large amounts of macrophages that will break down these bacteria and kill them. So actually, if we didn't have this arrangement of the hepatic portal vein draining blood from the gut directly to the liver, we'd all be sick all of the time. We'd feel sick all of the time. Also, foodstuffs. So food is going to be absorbed from the gastrointestinal tract and go straight to the liver. So, for example, if we take too much glucose, the liver will store that as glycogen. So that there's chemical processing of foods in the liver. The other monosaccharides, the fructose and the galactose, will be converted into glucose in the liver. So that the only sugar draining into the systemic circulation, back here out into the systemic circulation via the hepatic veins, the only sugar there will be glucose. Or amino acids, if we eat too many proteins, amino acids will be metabolized in the liver. There's deamination, where they're used to make energy, or transamination, where they're used to make different amino acids. Now if you're interested, you can freeze frame on this. I'll just zoom in a little bit. Just a slightly more detailed picture. So what we have here is we notice that the spleen, the drainage from the spleen goes into the hepatic portal vein. And from the esophagus, the lower third of the esophagus, from the stomach, from various parts of the intestine. All these are draining into this common hepatic portal vein, taking the blood to the liver. There's an arterial supply to the liver as well, the hepatic artery, but it's about 75% of the blood going to the liver is from the hepatic portal vein. So we have this arrangement. Now, what is the relevance for pharmacology here? Well, the relevance is that drugs given enterally, the drugs that we swallow, are going to go into the gastrointestinal tract and they're going to be absorbed. And when they're absorbed, they're going to go directly to the liver. And of course, drugs aren't supposed to be there. So the liver treats them very often treats them as toxins, breaks them down. And remember, it's only when the blood's been through the liver that it can drain into the systemic circulation here. So this is off into the systemic circulation. Where the blood goes all around the body. And if there's a drug here taken enterally that's absorbed through the hepatic portal vein, it will go through the liver, but only when it's been through the liver will it enter the systemic circulation. And therefore be available. And this is called bioavailability. So bioavailability. Can you see that the drug will only be available when it gets into the systemic circulation? So if the drug that's taken in here, some of that drug is going to be broken down as it goes through the liver. This is called first pass metabolism. The drug that's broken down the first time the drug goes through the liver. Only then does it become available. So an important concept in pharmacology there, bioavailability. In fact, we'll just define that, I think. Bioavailability. The proportion of an administered drug that reaches the systemic circulation in unchanged form and is therefore free to have a pharmacodynamic effect, to perform its function. Now, if we give a drug intravenously, 100% will be bioavailable because it's going straight into the blood, which is where we want it. This is a drug working systemically will only work when it goes into the blood. So if we give a drug intravenously, the bioavailability is 100%, and pharmacologists call that F equals 1. 100% of the drug will be bioavailable. But first pass metabolism is going to break some of the drug down. Now, as we've said, the liver is recognising drugs very often as toxins, and it wants to protect the body, the systemic circulation, from these toxins. That's its job. So imagine you'd eaten some poisons in your food, some contaminated food, or some food that had gone off. Then you'd want those toxins to be broken down in the liver before it got to the systemic circulation. So food toxins, bacterial toxins, as we've said, all go into the liver. The liver recognises toxins, breaks them down. And as far as the liver is concerned, drugs are toxins. So the drug will be metabolised in the liver, and a lot of it will be metabolised in the liver the first time it goes through the liver, and the liver will break drugs down into metabolites. And metabolites are typically more soluble and less toxic than the original drug, or than in any toxin really. So the liver is going to break them down. So not all of the drug is going to get through. So beta blockers, for example, a lot of the drug is broken down the first time it goes through the liver. Nitrates, glycerine trinitrate. If someone swallows the glycerine trinitrate tablets, nearly all of it will be broken down by first pass metabolism, not reach the systemic circulation. Therefore, the patient will not get relief of their angina pectoris. So drugs are broken down into the liver by the metabolic effects carried out, metabolic activity carried out in the hepatocytes, particularly in the endoplasmic reticulum, this network layer in the hepatocytes, which is where a lot of the enzymes reside that breaks down the drug. So the drug will be affected by enzymes which break it down to metabolites. But that will be affected, that will be done by enzymes in the individual hepatocytes. Now, this first pass effect is not always bad because some metabolites are useful. So, for example, benzodiazepines, the Valium diazepam type drugs, they very often have active metabolites. So the reason that the benzodiazepines are so effective at what they do, quite dangerous drugs in some ways, but also very effective, is because the metabolites are active. So the benzodiazepine is absorbed from the gut, broken down into active metabolites in the liver. And another classic one is codeine. So codeine, as far as I know, is not an active analgesic, but when the codeine goes through the liver, the codeine is converted to morphine. So when you ingest codeine, the metabolites produced by the action of hepatic enzymes in the liver hepatocytes are going to convert that codeine into morphine. And of course, as we know, morphine is highly analgesic. So drugs given enterally are subject to this first pass metabolism. Now, drugs given intravenously or via other parenteral routes, sublingual for example, when they get to the liver, they are already going to be diluted in the blood, and they're going to enter the liver via the hepatic branch of the hepatic artery. So this would represent the hepatic artery taking blood to the liver. This is the hepatic portal vein, the HPV. That's the hepatic artery taking blood to the liver. So if you give a drug parenterally, it's going to be absorbed directly into the systemic circulation first. That drug will be diluted in the total volume of systemic blood. So when that drug reaches the liver, it's going to be already diluted. And if it's already diluted, the liver's going to find it harder to get hold of it because it's not as concentrated, so less will be subject to first pass metabolism. But it'll still be there, so when a drug's given parenterally, it's still going to be metabolized when that drug goes through the liver. But proportionately less will be metabolized because the drug is already diluted. And the liver cells aren't going to take it up in such volumes because it's already diluted. But when we give the drug enterally, and it goes to the hepatic, through the hepatic portal vein into the liver, then that drug's going to be in high concentrations because it's just come from where it's been absorbed. Therefore, proportionately more of it will be broken down by the hepatocytes. So that's first pass metabolism. It's the proportion of drug broken down the first time the blood goes through the liver, particularly a problem with, well, not a problem, but a factor to take into account with enteral drugs. Actually, there are some enzymes in the gut wall as well that are partly responsible for first pass effects. So there's some metabolism of the drug as it is absorbed through the gut wall, then much more when it's in the liver for most drugs. This is important because it explains why we often give a higher dose of drug enterally than we would give if we're giving the drug parenterally, because we can only get so much of the drug through the liver to be bioavailable, the bioavailability. So typically first pass effects, first pass metabolism, are going to reduce the bioavailability of an active drug, or sometimes give us useful metabolites, and other times break the drugs down into metabolites prior to excretion.